Thank you. So yes, welcome to this session. I think it's a very well-conceived session. I like the idea, and we're really trying to get at what are some of the major advances, in glaucoma. And in my opinion, certainly this qualifies as one of them, OCT. So nerve imaging, we've really been driven to because interpretation subjectively of photographs, drawings, and so forth is inherently imprecise and variable. So now we have OCT analyzers that do provide quantitative measurements. Yes, they're compatible with EMR, which is nice, but the main thing is that they're much more quantitative and they provide harder, more solid information for us as compared with subjective evaluations. Certainly the assessment of these scans has enhanced the diagnosis of glaucoma and also glaucoma progression over time, and I'll try to show you some evidence for that to back up these statements. So first of all, in terms of diagnosis, certainly the diagnostic accuracy of OCT is better than other imaging methods that have been developed, GDX, HRT, other ones. There's no question that OCT has inherently better resolution and is winning the race for best technology. It's pretty much now established itself as the leading technology for glaucoma imaging. So we can move beyond that and now really look at how does it perform. So it turns out that in terms of glaucoma diagnosis, it really only has moderate sensitivity and specificity for detection of glaucoma. There's been a lot of studies on this, and I'll just sort of summarize them to say that it does provide very useful information when you're initially evaluating a patient. But can you rely upon this as a standalone test for glaucoma? Well, maybe not. You'll have some patients that have nerve fiber layer defects that are long-standing and due to other causes besides glaucoma, so it's not 100%. I mean, it's not very specific information necessarily. But it can be very helpful information that we use even for diagnosis of glaucoma in conjunction with the other assessments that we do, let's say intraocular pressure and visual fields. In combination with OCT can be very helpful for diagnosis. And it is certainly very accurate for identifying healthy nerves and large discs. So in this sense, it's fairly useful because there are many patients who are suspicious for glaucoma for a variety of reasons, and if they have a truly normal nerve fiber layer, that's helpful in identifying healthy nerve tissue. And I'll be showing examples of this as we go along, but really the more important application for it has been progression detection, and that seems to be its strength. So in terms of progression, it's quite useful to know if there's no change clinically. So you can have patients that you're following who are glaucoma suspects, and you may see some minor variation of the intraocular pressure or some other thing that you're following. But if you see this type of pattern that I'm showing here up above here on the left, really steady progression analysis curves, straight lines, no downturn, same exact pattern for a long time. You're not seeing progression. And it's very useful sometimes to have that information to know that somebody really is stable. Glaucoma patient. Here's a glaucoma patient that does have nerve fiber layer defects and does have actual glaucoma, but their nerve fiber layer is staying fairly stable. There's no decrease over time. And on the other hand, if you have a patient like this, it's quite useful in picking this up. It's very sensitive for picking up small changes. Here you're seeing a patient that's developing a nerve fiber layer defect inferiorly here. And you're also seeing that in the curves where they're dropping down. You can see more dramatic drops for sure, but this is just one example from, I think I took them from last week's clinics. So it's very common to see that, and when you do see that, it really alerts you to the progression. So it's extremely useful for that, and these changes often precede functional loss, so they can be very sensitive. And certainly if you have faster changes, this is a bad situation because this has been linked in with more visual field loss. And it does appear that OCT is more sensitive than visual field now for progression detection, especially when you have early glaucoma patients. So it is extremely useful for that. Now, the concept has, of course, come up that maybe we should combine these OCT structural changes with functional measurements, and then combined together, these will provide powerful evidence for progression and essentially 100% detection. Well, that's definitely happening at this time. Right now we do it clinically. We try to combine the information, obviously, separately, but there are some algorithms and some new tools that are being developed as we speak to combine this information, and they will provide very accurate information about progression in the future. So this is definitely coming and is already developed and being tested, and we will certainly see this in the future. But for right now, we do use them separately. Fact is that OCT does contribute greatly to this process. We have a lot of good machines now. The key thing has been that the resolution has increased over time. We had, earlier machines, earlier generations of machines. Unfortunately, the data doesn't, carry over from machine to machine. So every time there's new hardware, we have to get a whole new database. But it is an improvement. We use it because it's better. The resolution has increased greatly. We're now down to 5 microns with the Cirrus OCT, but that's already been improved greatly. And we're now seeing machines that are in development that are 1 to 2 microns in resolution, which will be really spectacular when we have that. So the machines are getting better and better all the time, and that's providing more and more powerful information for us to use. How do we interpret these things? I'm going to give you a few practical hints. We do have, the way I look at them is I look at a few things on the scans. We use the spectralis a lot, but we have the Cirrus as well. We have all of them actually, and multiple machines of all of them. But anyway, we have a normative database. It's important to use that to compare the information you have about the patient to what's normal. We have quadrant analysis and also sectorial analysis. We pretty much only use the quadrant analysis because the sectorial analysis has relatively small number of scans, and it's not inherently quite as reliable. But green means it's normal. Yellow is in the lower 5% of normal. Red is in the bottom 1%. And white is in the top 5% or higher of normative database. So this is useful information. If you see red, that's bad, and it's abnormal. So it makes it simple for us. We always use the average RFL analysis, which is printed on the Cirrus in these little boxes up here somewhere, the average. In the spectralis, it's in the center display of the quadrant analysis. And the average number we always record for every patient, because if that shifts greater than 4 or 5 microns, you know that there's something significant going on as well. The disc area I oftentimes look at, that's one of these little numbers here in these boxes. Greater than 2.0 disc area is abnormal, and this is very helpful for identifying patients that have large discs. It's a congenital anomaly. It's very common, and if you see a patient that has large cups, but they have large discs as well, and the neurofibrillary analysis is normal, that's essentially a normal person. But they may have very large cups, so it's quite useful to have the OCT information to see that. So in terms of what we accept for minimums, you got to have a reliable scan to compare them. So for the Cirrus, the cutoff is, they're different for each machine. So the Cirrus has to be greater than 6. Spectralis greater than 20, greater than or equal to 20. Rediview, it's greater than or equal to 30. Here's the Cirrus. You see it has to be, these are a couple of unreliable scans. You have to have greater than or equal to 6. And then this one is also, I think this one is unreliable, this one isn't. But this is just barely reliable. But you can see, you start seeing neurofibrillary analyses that are not really very reliable if you get these, quality of the scan is very low. So you have to get a good quality scan. There are several other artifacts to look out for. Media opacity is a very important one. That can be due to many things: cataracts, corneal disease, pupils may be too small. It can be, it can capture an image through a very small pupil, but it can be too small. And then thinning artifacts, and image non-capture, maybe due to image non-capture as well. So movement artifacts, something really important to look out for: blinking eye movements, nystagmus, and that's manifested here. You see when you see these dark areas on the Cirrus, this is better, but this is a lot of movement artifact, and that shows up as having a lot of red areas. This is the same patient that just didn't move as much, and so you've got a good quality capture there, and these are more reliable measurements than these over here. So then you've got algorithm segmentation failures, which the algorithms smooth areas. So you can have an actual neurofibrillary defect. This is a patient that has a neurofibrillary defect and a visual field defect, and yet their neurofibrillary analysis doesn't pick up the RNFL defect. But there is actually one there. It's right here and here. So what it does is the algorithm, if you get to small areas of neurofibrillary, will smooth those over, and so you can have what we call green disease. That means you're picking up something that's green, but it's not really normal in the real life. It's actually got a small defect. So you can have various artifacts. You have to look out for them. And they're important to kind of look out for. If you get a certain degree of RNFL dropout, you can have essentially so much dropout that you can't really detect any further change. This is really at the bottom of the scale. This is a patient that had really advanced loss, but if you get to this point, it's hard to pick up change also because it's at the bottom of the measurement, really. There's various other non-glaucoma abnormalities that you will run into. You can have the incorrect scan distance, high myopia, peripapillary atrophy, various other things that will cause abnormalities related to the patient, related to the scanning operator, rather. The patient may have various abnormalities that may cause things that are not normal, but it's not glaucoma. This is peripapillary atrophy causing a little bit of red areas here, but those are not because of glaucoma. And here's a patient with myopia, again, some red areas, but not because of glaucoma. So, you know, this is why the glaucoma diagnosis, we have to get these baseline scans, then we can follow progression very accurately in these patients. Now, the impact of this has been huge, absolutely huge in clinical practice. Clinicians in the USA now use OCT for glaucoma evaluation and detection. In India, now, according to this paper in 2017, last year, we're a couple months out of date, but 3/4 of glaucoma subspecialists use OCT, and 83% use visual field. So here in India, I keep getting accused of bringing in, you know, USA technology and stuff that's not relevant. Here in India, it's relevant. You can use OCT. It's being used now, and it's highly helpful for using OCT. OCT has been a top advancement in glaucoma during the last decade, and I would say that with no doubt. You know, we're talking about advancements. So in conclusion, OCT has an important role in glaucoma evaluation and progression in monitoring for progression. Assessment and clinical interpretation of OCT scans is a judicious process. You have to be careful as you look at them. You have to be able to be aware of artifacts. They can occur, and they can confuse your interpretation if you're not aware of them. You're looking for things that cause false positives. You might say red disease, or false negatives, green disease. But ultimately, we do interpret these scans in context of other clinical observations for sure, but we're finding really direct use for these scans now these days. And so again, I would assert that it has indeed been a very top 5 type of advancement that we've seen in the last 5 years. Thank you very much.